going to talk about again the green top guideline number 75 about cervical cerclage. Now in this video we'll talk about the different approaches or the techniques by which a cerclage can be placed in a weak cervix. Now there are basically vaginal and abdominal approaches to place a cerclage. For the vaginal or the transvaginal approach, we have the McDonald cerclage, in which the cerclage is placed at a level where the urinary bladder does not require mobilization. It is not pushed up. That is the McDonald cerclage. Then we have the high vaginal or also the Shirodkar cerclage. Now what is the significance of high vaginal? High vaginal means that we need to mobilize the urinary bladder, otherwise this area will not be approachable. Both these cerclages are placed through the vaginal end, and the levels at which they are placed is the cervico-isthmic junction for the McDonald cerclage, and a level above the cardinal or the McEnroth's ligament is chosen for placing the high vaginal cerclage. Now it is high up, so definitely it is above the level of the cardinal ligaments. Then we have another vaginal approach which is known as the occlusion cerclage. Now this is a not very routinely practiced cerclage which is placed at the level of the external os, and the main idea behind placing this sort of a cerclage is to facilitate retention of the cervical mucus plug. So this is the main idea behind the occlusion cerclage. Now we come to a very special type of cerclage, which is the transabdominal cerclage. Now it has got two approaches, laparotomy or laparoscopy. Now when we are doing a laparoscopy, the complications are very less, so wherever the expertise is available, in fact for all the cerclages that we choose, it is very important to choose it according to the surgeon's expertise. And wherever possible, the cerclage should be placed as high as possible. Now when we talk about the laparoscopic surgery, of course surgeon's expertise is the most important criteria to choose a laparoscopic cerclage, and the complications are very less in case of a laparoscopic cerclage. Now when we talk about the level, then the laparoscopic cerclage or the laparotomy cerclage, that is the transabdominal cerclages, are also placed at the cervico-isthmic junction at a higher level. So this is the level of the transabdominal cerclage, which can be placed either abdominally or laparotomy or laparoscopically. And the vaginal cerclages are the McDonald cerclage that does not require bladder mobilization, or the Shirodkar cerclage, which is placed after the mobilization of the bladder of the cardinal ligaments. And then we have the occlusion cerclage, or the one which is placed at the external os. So this is a broad classification about the approaches or the ways cerclages can be placed. Now very common or very easy way to understand cerclage is placement of a hair tie. If this is a woman and you place a hair tie here, suppose if we place a hair tie over here, it is supposed to grab almost all the hair strands. But if we put a hair tie here or lower down, then we will see that hair will tend to come out. More and more hair will come out. So the strengthening of the hair tie depends on how high we can place the tie. Similarly in cerclages, cerclage should be placed as high as possible for maximum strengthening. Now, if we talk about the suture material, of course, it is either the polyester braided or the Merceline tape which is used. And for occlusion cerclage, we can use non-absorbable suture which is placed as a continuous suture. For the other approaches, that is the vaginal or the abdominal, we basically place a purse string suture. Now, very important specific criteria that is chosen for the transabdominal cerclage is that you can place it even before conception, that is even before the lady is pregnant. If there is a condition which is an indication, the history is indicative of a cerclage which will be needed in the subsequent pregnancy, then we can place it even before conception. And what is the benefit of placing it before conception is that anesthesia that you're giving is on the non-pregnant uterus. So the baby is escaping all the anesthetic risks. So the pregnancy associated issues with anesthesia are easily avoided. There is technical advantage of operating on a non-pregnant uterus. And of course, it has been found very important information that no detrimental impact has been found on fertility or the care and treatment of early miscarriages. So, even if there is a problem and you require to place a transabdominal cerclage, and it is possible to place it before pregnancy, fertility, or the management of early miscarriages will not be impaired. In case you miss the preconceptional time and the patient comes to you in the first trimester, then the ideal time to place this cerclage is 11 to 14 weeks. And a very important thing to know, what is the indication for transabdominal cerclage? If there have been previous unsuccessful transvaginal cerclages, or there has been extensive cervical surgery, so much so that the cervix has lost a lot of tissue, then in those cases, of course, we have to place a transabdominal cerclage. And after you place a cerclage, it is very important to frame a plan for when to remove the cerclage so that the person who's managing the labor knows about it. So, cerclage has to be removed before labor, preferably 36 plus 1 to 37 weeks, that is at term, that is just before labor. And the anesthesia which is to be used for the removal of high transvaginal cerclages has to be discussed with the lady and then decided about the route of anesthesia. For transabdominal cerclage, LSCS is the choice of delivery because it was placed abdominally. So you have to go for a LSCS birth after transabdominal cerclage placement. After the LSCS, if more pregnancies are anticipated or desirable, you can leave the transabdominal cerclage in situ for the next pregnancy also. So this is a wonderful advantage of the transabdominal cerclage. And last but not the least, cerclage with pre-prom. This is a very important guideline because any foreign body in a pregnancy with pre-prom is not acceptable and you have to remove the cerclage. It's very essential. Only and only in gestations between 24 to 34 weeks, you can keep the cerclage for 24 hours. For 48 hours to facilitate in utero transfer if you see there is no sign of preterm labor or no sign of infection. So only in 24 to 34 weeks of gestation in a patient with pre-prom but no labor, no infection, you can keep the cerclage for 48 hours to facilitate in utero transfer. Otherwise, apart from this, if the gestation is less than 24 weeks, more than 34 weeks, any other scenario, or in this patient, this gestation with infection, with labor, any other scenario, the cerclage has to removed right then and there. You will not even wait for 48 hours. Be prompt with cerclage. Cerclage has to remove then and there, except the special condition, that is can be kept for 48 hours. If there's no infection, no labor, pregnancy is between 24 to 34 weeks. So this is in a nutshell an idea about the approaches or the placement of cerclage according to the Green Top guideline. Thank you.